that it's kind of tough to hear. Our speakers up front, the microphones that are on the desk seem to work pretty well. They're a little more forgiving than the one on the podium. So we've got lots of time here for discussion and questions. Hopefully we've got lots of questions. I think I'll start off with one here, and we have an honorary member of our panel, Steve Casco with HPD here. And one of my questions that I've heard lots of theories about this, but why Houston and Texas seem to be either delayed or so much slower or so much less on the opioid front. And I think these are the guys that actually deal with trying to bust all this stuff and deal with these things. So there's a couple of different aspects of that, of what you see as trends that may contribute to opioids not being quite so prevalent here, but also some of the trends in data collection and things like that that you see maybe contributing to the issue.
All right, in my 2 minutes I've had to prepare for this. Here in Houston, drugs are very, very cheap compared to the rest of the country. We're next door neighbors to Mexico. I can talk really loud, that's okay. Here in Houston, the price of a kilo of meth is about $5,000. You go down closer to the border, it's about $3,000. If you open in the northeast part of the country, it's $20,000 to $30,000. Very, very cheap here. It has a tremendous price increase. Both methamphetamine and cocaine have a tremendous price increase from Houston up to the northeast. Heroin not so less. The Mexican cartels very much wanted to take over the northeast heroin from the Afghans and Canadians. So they kept the prices very low, shipping costs were very low, and they got it up there, and it doesn't seem near the price increase. Last year, finally, they had a lock on it. The New York, New Jersey Highway reported last year that Mexican heroin finally took over as #1 heroin in the New York, New Jersey area. So their marketing very much worked. So if you lower the price of heroin to take over for people that are already heroin users, you're going to suck in a bunch of heroin users because the price is very low. A kilo of heroin here in Houston is $40,000. So not that a meth user is going to switch, or a heroin user is going to switch to meth that is cheaper, but when you're that first-time drug user, when you're 15, 16, 17 years old, are you going to buy a $200 ounce of meth, or are you going to buy a $2,000 ounce of heroin? It's just what you're going to get started on doing that. In terms of data collection, one of the problems we have is even finding out about people that are overdose. Right now in Texas, if someone shows up at a hospital alive, suffering from an overdose, and dies, at a time reported to the police. So we don't know. For me to get autopsy results back from the Chinese office takes about 8 months. So if we stop finding out someone died with a fentanyl, heart medical, something like that overdose, we find out about 8 months after it happened, and then we try to retroactively go back and do some sort of investigation, which is crap. It doesn't work very well. Dates are gone, evidence is gone, people don't want to talk about it, nobody's scared of anything, it's just out of the realm. The Austin right now, us, HPD and San Antonio are trying to get a law passed where if you show up in a hospital alive and you die while you're there, they have to tell the then they have to tell the police. That's not the law. I have an email that says not no, but hell no, when I ask about, hey, you release call us when someone dies. No. They have lawyers, we have lawyers, everybody has lawyers, and they're all mocked up right now. Yeah, I'm trying to get this done. Yes, if somebody calls on the floor right now, if you call the fire department, 911, and he says someone's suffering from an overdose, the ambulance and the police car would show up. And we would know. Yeah, if you call and say, hey, someone's had a heart attack, someone's not breathing, someone's unconscious, someone's down, and I don't know why, the police would never know about it. They pick that person up, they take him to the hospital, they die of an overdose, we never know. And again, we'll wait 8 months on an autopsy result from the MD's office, and then we find out about it, and then try to find everybody here in the room 8 months later and ask you what you saw, which is not good. Yeah, only 5% of people in Harris County have autopsies. So, 1 out of 20 people, we really know why they died. So, at best, we have 5% of the information, if it gets reported. So our data collection is really the whole worry.
Thanks, yeah. So I think same question for our panel up front of what are the things that you all see from kind of the national perspective? What do you see that makes Houston, Texas not be in the same places like West Virginia? And Paul, I think you had some numbers of some of the other implications of statistics in West Virginia, things you're seeing there.
You know, I do appreciate the economics lesson we got there about what happens when the price is lowered, so my hat's off to you on that one. One of the things that we're seeing that, just to pick up on the comments that were just made, this is an issue nationally with getting good information about the reporting. And this is part of the conversations we're having with the CDC and with NIST is, how do you know when opioids were part of the death? And we do not have a good systematic reporting system in place to discover this. It's often by happenstance. And if you think of who is it that might be reporting a death, that in many cases you're not talking about a medically trained individual who's serving that role of coroner. And so, what they put down on paper and what is reported, so it's very, very difficult to use those numbers at all to try to get a sense of what the magnitude of the problem. So I would reiterate the points that you made here. We're understating the nature of what the problem is because there's such a huge portion of it that we just don't have good information that's coming from. And these are the kinds of things that we're trying to do, is to work with various groups to see who's involved. Even the Department of Justice's information that they have coming from the laboratories, while they've done a good job in identifying forensic laboratories, they don't get the same reporting information from coroners and medical examiners. And so it's really a big issue nationwide to be able to put all of this together to appropriately influence policy to try to figure out what the answers are going to be.
Any of our other panelists? I know one thing I saw was, I think, a University of Pittsburgh public health study that came out a couple of months ago that was estimating that the number of deaths since 1999, opioid overdose deaths in 1999 has been understated by some 70,000, because that, while cause of death may be overdose, cause of death being opioid overdose is not necessarily making it to the death certificate. So when we're trying to compile numbers either locally or nationally, we're not able to see that it's opioid overdose and that it's being pretty substantially understated. So I think they estimate there's something like 250,000 opioid overdose since 1999 to 2016. 70,000 on that. I mean, that's a pretty substantial percentage.
I also might suggest that you don't have unemployment at the rate that we have unemployment. I honestly do not know how that figures. I can't imagine how that figures. That might be a question we need to think about. But certainly in Appalachia, as you look at Appalachians, you also must include a great deal of Southwest Ohio. You have to look at the long-term meth which occurred years ago and whatnot. A lot of that was related to unemployment, and again, I'm not sure that Houston has as huge a problem with that as we might.
Yeah, just picking up on that. If you look at any map that is showing you the number of opioid deaths per 100,000, or any type of thing with respect to drug use, it's almost the same map that you would see if you wanted to look at where unemployment rates are highest. And so certainly in the state of West Virginia, if you're not familiar with it, if you flattened out West Virginia, it's bigger than Texas. Think about that. We are the smallest state that is not literally on the Atlantic Ocean. We're the smallest state. But the size of it and the difficulty of the terrain. So if you begin to look at the southern counties, which are all the coal counties, and they are fairly mined out, you have the two highest opioid deaths per 100,000 in the country, two of those counties. Those two counties also have unemployment rates of 50%. And this is after a lot of the population has already left. So it is very much related to an economic problem as well as a mental health problem.
And I guess I can't say if this is a factor for certain, but Houston is a very large and diverse city, and no matter, like, whatever kind of food I want to get, I can find it here. And the same looks like to be the same for drugs, because we get a huge variety of different substances. We get PCP, we get all sorts of different clandestine ecstasy tablets, we get psilocybin mushrooms. In addition to all of the common stuff, we get a lot of the N-bombs and the complicated synthetics and different derivatives like that. I don't know if that's a factor, but there's a huge variety to choose from. So maybe it's a matter of options. But we don't get Bufontein and toads, and I want to work one of those.
Is there anybody here from DPS lab or other toxicology labs? I know we've got some HFSC folks here, and one of the things we see in toxicology is as a capacity issue, if it is an alcohol, in a driving under the influence case, if you've got an alcohol concentration at 0.1 or above, we don't test for drugs. We just don't have the capacity to test those for drugs. So when we see upwards of 3/4 of our cases that we do test for drugs have more than one drug on board, we're probably not reflecting the pattern of drug use. We're underestimating in the snapshot of the pattern of usage of drugs within what you get when you get driving under the influence of drugs. And my impression is that's basically the same with other laboratories in the state. Is there anybody else? Yes?
We're at Brazoria County, we don't test for drugs if it's over 0.08 alcohol, unless it's requested by the DA.
That's kind of the impression I get. It's basically all the laboratories in the state. So effectively statewide, we are significantly underestimating the number of drugs that are on board with driving under the influence. So I do worry in Texas that part of our, we rest on, well, opioids aren't as much of a problem here as they are elsewhere. I'm afraid we're underestimating, actually, the problem that's here. What are the questions we got? I've got questions here, but there you go.
Hi, I'm Greg Jellick with Quality Forensic Toxicology. We're a private lab in San Antonio. We do hear the frustration from other cities, DAs, with the policy of the 0.1 and you stop. One particular DA conveyed that she needed to know whether or not this doctor who had gotten pulled over for DUI was taking her own hydrocodone pills. And they could not get the state laboratory to budge on that. So, because they would have stopped, she also had a blood alcohol concentration at above 0.1, so they would have stopped. But there are other resources like our labs, like the Houston Forensic Science Center that can circumvent that on request. So, I did have another question too, unless we want to go back to this one. How do we get more doctors authorized to prescribe Suboxone? My feeling is that ultimately this is going to be the miracle drug, if you will, to have long-term treatment, but there's, as someone pointed out, there's not enough people actually prescribing it. How do we increase that number of doctors able to do that? Oh, okay, yeah. Suboxone is buprenorphine, which is essentially a drug that sits on the opioid receptor and reduces the cravings that you might otherwise want and the pleasurable feelings you might get from taking opiates. It also has an interesting ingredient too, which is naloxone. Typically these substances have naloxone built into them as an abuse deterrent. So if you try to crush them up or dissolve them and inject them, you're injecting naloxone, which blocks the effects of opiates. But that's the toxicology side of it. The health side of it is that this is going to reduce the cravings for somebody as long as they're taking it. And they've shown that you can take it for many years and not have any long-term, negative long-term effects.
Suboxone and Suboxone patches are also a big item on the streets in Cincinnati now, to eventually help you with your own detox so that you don't go through detox. So people have found a black market for Suboxone because people do. But we have some doctors that do in fact prescribe. They have very vigorous business.
As far as increasing the number of doctors who are willing to prescribe it and who actually do, I know that locally there are some programs that are supposed to assist doctors who want to prescribe it, education programs. I believe MD Anderson has started one of those. I think part of it goes back to when you're in medical school, putting an emphasis on addiction treatment and also encouraging more doctors to go into that as a field. There's still a lot of stigma of going into addiction treatment from medical school. One is, not wanting to deal with, addicts or however people want to view them. The other is the fact of the reimbursements, and you have medical bills to pay. A lot of people want to go into fields that they can get larger reimbursements for. So there needs to be a change in the incentive structure there. The other thing right now is that there are, we know that there are doctors here in Houston that have gotten the training to prescribe buprenorphine, but even people that get the training to prescribe it aren't necessarily doing so. I think either they're not comfortable with it, and that's where I think some of the training and education on it can help. But the other component to think about here is that when we talk about doctors prescribing buprenorphine like in their office, I think that's really helpful and more convenient for some people versus methadone where you have to go to a clinic every day. But often when you're getting it, if you are getting buprenorphine or Suboxone from your PCP or other doctor, you're not getting the therapeutic component. And if you want, the Suboxone in that case can help in the short term with satisfying cravings, and maybe people won't be trying to buy heroin off the street. But if you want to help them towards a longer term recovery, the therapeutic component is really important as well. So we need to think about how to coordinate those two things and better integrate those two types of care.
Reggie Smith with the Texas Criminal Justice Coalition. So I know we see in the policy area, and at least in the last couple of sessions, we've seen a lot of diversion programs for people with substance use and mental health. And we've seen a lot of new uses for peer support here in Texas. But we're kind of late in the game. Now, I know Judge Thomas, you spoke about it, and of course, Leonard, I'm sure you've been using peer support for a long time. I'd like to hear from these other parts of the country about peer support and how effective it is, or do you know about it, and are people using it to help people get off substances?
Other parts of the country. Is it you? I don't know.
Is it you?
You asking about other parts of the country first?
I was asking the other people from the other parts like Appalachia, from where other gentlemen is from, if they're familiar with peer support like we are using here. We're kind of late in the game to it. People in the Northeast have been using peer support.
I don't really know.
Apparently they're not using it that much that people know about it.
I'm just a journalist. All I know is that I think we have all kinds of things. There's much policy discussed now about whether or not hospitals, if you come in for an overdose, can send you immediately to a rehab facility. The rehab facilities have to exist for that to happen. In Kentucky, there's a thing called Casey's Law, which allows a parent or some sort of affiliated relative to basically incarcerate you to a rehab facility for 30 days, basically for your own safety. We know stories of law enforcement in Ohio driving to the middle of the Roebling Bridge and handing people to Kentucky because Casey's Law is so much more effective in getting at least some additional 30 days of treatment to start. So essentially law enforcement is coming up with its own answers in some ways. We have the police officer, chief of police of a very small town called Newtown, who's becoming sort of a worldwide heroin expert because he's basically going around and explaining to law enforcement about how this should be handled. Our jails are learning how to do detox. They didn't when we were doing this story, but essentially now we have a 108-bed facility in jails. Usually when we were doing the story, they were given Tylenol and told, buck up, buddy. We also had a mother this is not in the story, this was previously, a mother who has been convicted of murdering her own child because her daughter was going through detox in jail and she smuggled heroin into her and she overdosed and died in jail, but essentially that's delivery of the drug. But essentially she just loved her child so much she didn't want her going through detox alone without the drug. So essentially we have a lot of these sorts of stories of how we have to sort of do we have to understand how rehab works and how it can work policy-wise.
Let me try to rephrase my question a little bit. Since we have these diversion programs, because when judges like Judge Thomas want to send people to the community, they need programs in the community. So what I'm saying is, since we have so many people that we're trying to divert into the community, we don't have the infrastructure for that. We don't have that support, that reentry support, or that recovery support. What have you seen in your locations that addresses, the support that people need that are coming to you from these programs that you're talking about?
Let me give you a good example. I don't know if anybody has seen the documentary on HBO, Recovery Boys, just released this past month. That is a good West Virginia story. Where it comes from is there was a group of physicians that had created an urgent care system, MedExpress, that I think they just sold for $1 billion or something to Sequoia Capital. Very successful. And one of the founders of that discovered that his own son, former football star, Morgantown High School, had an addiction problem. And there was no really good longer-term care program that existed in West Virginia. So he created one. So Preston County, one of the northern counties, he bought a farm, and it was a working farm where he would take addicts in and a 6-month program to be able to succeed, and then would move them to a sober living facility. We have very, very little, and if you watch Recovery Boys, you get a very good idea on this. It is sad. It is very, very sad. But there's also some great successes that occur in there. But it's the lack of really good facilities to maintain the success. Now, we do have a sober living house in Morgantown itself, run by the son of one of our big bankers, who had an issue himself and changed his career around from a finance guy to simply helping people deal with this on a daily basis. But they are few and far between. I'll tell one other Northeast state story, and again, this is just reading about it, but Manchester, New Hampshire is a city that has a long history of a very, very serious heroin problem. Again, economic in many respects of it losing a lot of its facilities. Go Google this one, take a look at what they did. They looked and they realized that every person who is addicted, at least once every day, wants to do something about it. But where do you go? If I go to the police, they may arrest me because what I've been doing is something that is illegal. I don't know what hospital has a bed or where the treatment facilities are. They opened up the doors of every firehouse. Just knock on the door. No questions asked. We will not report you to the police. We will find you help that day. We will find you a bed. And their problem fell in half almost immediately. I think there are some good stories out there, but what you're asking about being late, everybody's late to the game. And it's finding and sharing the things that do work, and perhaps finding those things that may happen on a more wide-scale basis, and be ready for those things.
And, just kind of stressing the importance of what your question addressed, for what we're doing here, and again, by stepping off into this and trying to take a different approach to this wide swath of cases, these less than a gram and 1 to 4s, we are still most certainly a work in progress and much closer to the beginning of what we're trying to do than towards any end goal. But certainly we have all recognized, without getting too deep into drug policy and everything, that of the portion of those cases that we're dealing with that deal with people that have a substance use disorder or some type of addiction, we know that confinement in and of itself without some kind of appropriate treatment is just not going to yield effective results. It just doesn't work. We do know also that treatment does work and recovery is possible. But, as we try to navigate that space to divert people away from jail towards appropriate treatment, there are so many things that affect that. I mean, treatment is part of it, as Dr. Harrison mentioned too. When we talk about medically assisted treatment, that is something that can be appropriate and can be effective. None of these things in and of themselves are the be-all, end-all, or the answer to all of this. It takes a multitude of things and a system, a change systematically for us to get better results with that. And so when we look at the diversion part of it, we're very aware of diverting people away from jail. That's part of it. But it's what are we diverting them towards, and what are we equipping them with? And one of the issues that we, by taking a pool of people that the majority were going to jail and staying there and going back through the system time and time and time again, and taking that group of people and trying to divert them towards treatment and putting those out into the same resource level that was out there, you're stretching what was already stretched, much thinner. And so those are things we will have to address. But we don't get there without first making the intentional effort to do something different. But there are so many things that go into that. And the peer support and the recovery coach part of it, and we have part of our team that are here, Jackie Works, that works with probation, and Mary Covington, our director, but Cedrina, who's also here and works for Leonard, but we claim her, she works with us as a recovery coach. I cannot stress to you the importance of that. When people are making the decisions about, do they accept this pretrial intervention or this divert adjudication? People are very skeptical, for good reason, of criminal justice in our system. And no matter what our intentions may be, and even if our heart's in the right place with what we're trying to do, what we say, what they hear, and how receptive, that's not always the same thing. Having people that can, as appropriate, walk alongside of that, to have kind of a shared experience, to answer the real questions and the concerns that somebody might have, and also to point to that and see that is somebody that made it. I can't understate the significance of that. And again, also, we have to understand this is a process. Giving somebody deferred or pretrial intervention and say, here's your chance and good luck, that's the beginning of it. That's nowhere near the end of it. And so having people that can help walk alongside that can be a supplement to that, will never be effective if the sum total of what we do is just giving people a chance. We have to be able to continue to work with those chances and work through it. That's what we attempt to do. We're not always successful at it, and we try very hard to engage and look at, bottom line, simply put, we try to do more of the things we do well and less of the things we do bad. And that's a process that we figure out. But the recovery coaches are very important in that. And one thing we utilize them differently is there are many places that may make a referral to a recovery coach. They are with us in the courtroom every single day. The hired attorneys understand that and begun to know who they are. The attorneys that handle either the PD's office that does some of our indigent work or the private attorneys that do indigent work, they understand they're there. And they can use them as a resource, use them as appropriate, and they have the freedom to do that. And I can't tell you how important that has been to us, not just in trying to, make it appealing enough to where people will engage in giving us a chance at that, but also continuing to work with them at that. None of these things in and of themselves are the be-all, end-all. This is hard, sticky, tough stuff that, we have to be in it for the long haul, but all of these different pieces to it are critically important, and that peer part of it is huge, because we all think that we're smart, on this end of it, and we know what people need to do and how they need to do it, and the stuff we're talking about and we're thinking and the stuff they're hearing and they're receiving aren't the same thing. And, having people that kind of can step into that and speak to that is huge when it comes to this.
Judge Thomas, I know that you worked as a presiding judge over the drug courts, and you now work in the mental health courts, but between that time, you worked as a defense attorney as well. And I'm wondering, in all of this, from your drug court days to now, have you seen a significant overlap in the clients you see in your drug court and your mental health courts? And if so, how has that affected how you structure your approach to recovery and assistance in your mental health courts as compared to the way you handled it in your drug courts?
Well, I think, I think we've always known, but certainly we're much more aware now of the fact that, a large number of the people that are coming through or justice involved that are dealing with a substance use issue also have a co-occurring mental health issue. I think systematically, the way we have approached that in the past is get the mental health over here, get the substance use over there, and not in the right approach, which integrates the two of those things. We're still working through that. We have programs that address that. But I certainly think just from a standpoint of an awareness, it helps. I have presided over a district court with the rapes, murders, robberies, and everything else involved, and not here to say that for every person, diversion to treatment is appropriate or works. I mean, you have to look at the facts and circumstances. But with these low-level cases that cycle through again and again, we just got to figure out a better way to do it. I mean, the reality is, the people that are in jail across this country, 95% of them, the thing they have in common is they were all getting out. I mean, whether it's tomorrow, next day, next week, and with these low-level folks, we just got to figure out a better way to address it. And the officers that are here, they understand, especially, a lot of these people they're seeing over and over and over and over again, and we cycle through that. We've got to figure out better ways to do it. And just that awareness, I know what drug court had taught me and mental health court taught me, as I said before, just the recognition from a judge that, treatment works and recovery is possible, and you got to have an openness to that to begin with. And, being able to see, working with people, we're not a drug court in that we deal with all levels of cases, but we certainly utilize drug court, mental health court as appropriate for those higher level folks with higher level needs. But, when you have that interaction, in that closeness with that, you can't help but to start recognize that these numbers are actually people, and we can talk policy, we can talk theory. What we deal with in our RIC court every day is real life. It's 5,000 cases a year that come through, and it's like drinking out of a fire hydrant. And the number of cases and the circumstances, and they cross spectrums. But we certainly do see that overlap. That's one of the reasons that in addition to getting people legal the right level of treatment, we actually have, in addition to recovery coaches that are there, we have folks with the Harris Center, the mental health, our local mental health authority, they're in the courtroom with us every day. So it is not hey, we will set you up to talk to somebody. We can literally step over to that table, or refer their attorney to it, and to be able to get some linkage and at least off on the foot right then and there. So part of this is leveraging resource quickly and appropriately, and that's one of the things we can do. And it's a benefit to the 22 district courts because we can take the time to do it. That's less that's on their plate that they can be dealing with the other cases that they certainly need, the higher level drug cases, the violent crimes, and the things like that that need appropriate attention. I don't know if that answered your question, but...
Other questions?
One thing I do want to add is that I'm sure the judges, he may have said this, but there are a lot of kinds of crimes that look different. They don't look like drug crimes because it's not, we confiscated drugs from you. They are burglaries, they are child neglect, they are robberies. I mean, Dr. Speaker and I were talking about a young man he knew who committed bank robberies in order to support his habit, and essentially, is that what you were referring to? I mean, again, we underestimate sometimes these things because we're not actually counting that as a heroin crime, but in fact that is a heroin crime, right? Because essentially what people are in jail for is trying to get money. Prostitution is the prime example in Cincinnati. prostitution's not the problem. The problem is they need a fix, and they need money for the fix.
The fentanyl numbers were very striking, and I was just wondering if you all had an idea of how much of that was the user was actually intending to use fentanyl, or whether it was like laced in, they thought they were doing heroin or something else.
Well, I can speak from the lab's point of view. Like I showed in the examples, a lot that we get are very, very orchestrated to look like a prescription opioid. Like they are really high quality fake hydrocodones or fake oxycodones. And I have no idea whether they're being sold as fentanyl that looks like that, or if they're just being sold as the more expensive opioid. And if I had to believe which one somebody would do, they'd probably pick the more expensive option. But that's speculation on my part. In terms of the submissions, we get a lot of submissions that come in that they think may be fentanyl and they turn out not to be. And we get a lot of submissions that are submitted as meth or cocaine and they end up being fentanyl. So in terms of what the officers understand, there's still a lot of distance between them actually being able to tell this is a fentanyl case and this isn't. And that may reflect what's happening elsewhere.
To add to that, Patrick, my name's Brooke Knapp. I work at the same lab that Patrick does and sees drugs. The carfentanil case that he showed that I had, it was the first one in Texas that was reported to DEA, and that was in 2017, so that was last year. The suspect argued with his attorney and with the officers that that was not carfentanil, it was just fentanyl. So that's a pretty good or a reasonable assumption that a lot of these people don't know what they're getting. They have no idea.
We do know from some of our assessments that are done and some of interaction that we get with people that are participating in our programming that we have many folks that maybe a heroin user had no idea that fentanyl was mixed in it. A lot of times that's the case. Sometimes we have people that's what they intended, and everything you can imagine. I mean, again, all of these substances, they're not purchasing them in Walgreens and they don't come with, the disclaimer and all the, components written on the back of it. We get people that get arrested for a meth case, they get arrested for a heroin case, and it turns out to be a meth case, and they're astounded to their attorney, like, what do you mean? I thought I was getting heroin, so we've had it all, when it comes to that, whether it's intentional or unintentional. The reality is, these folks, you don't know what you're putting in your body and possessing, and, it's complex.
Yeah, I'll follow up with that. We had in Huntington, West Virginia, so over near the Ohio-Kentucky borders, a case about a year ago in which 21 overdoses in 1 hour.
Oh, Lord.
And interviews with people, none of them, they all claimed not to have known that the fentanyl was in that. So we thought that was awful until a couple weeks later, they had 19 people in an hour in Charleston, West Virginia, in our capital. So it appears that certainly a lot of cases, people have no idea what they're putting in their bodies. There may be some that do, but at least from a couple stories you hear, it's like, no, they're just taking whatever they take.
Right, we kind of look at it that the number of drugs that we get submitted as fentanyl typically aren't, and all kinds of things that are submitted as something else end up being fentanyl. One of the questions I had for Catherine, you were talking about the test strips for users. Do you have more on what those strips are? What's the...
So the strips can actually, the way that they, like if you have heroin when you put it into liquid form before you were going to shoot, like if you were going to shoot it up and you put it into liquid form, when it's in that liquid form you can put the test strip in it and it'll show if it tests positive for fentanyl. So I believe that the strips were originally designed to test if somebody had fentanyl in their urine and somebody was able to kind of change the way they were able to use, so they could be used to test an actual heroin sample. So they are something that, again, you can distribute to people that can use it to test the drugs before they actually take them. And it doesn't necessarily mean that people aren't going to use and get high, but it might, modify their dose if you provide that to them. And I believe that the strips cost around $1 each, so not that expensive, although, if you have people wanting multiple strips, but it's a way that I think we can reduce the more risky use patterns that we see.
Yeah, I'm just curious, if you've got a link to that or some information.
Yeah, I can.
It's the difference of the chemistry that may be going on in that and what we see with the typical field test kit that reacts basically with fentanyl the same way it does with methamphetamine. And so the carfentanil case that we've talked about, that one came to us as methamphetamine. The officer in the field tested it, methamphetamine, so the officer was thinking it was methamphetamine, not carfentanil. And the other one that was here in Houston was the fentanyl flyer, flyer that everybody thought was fentanyl. The officer, started feeling funny for whatever reason, but the paper itself cross-reacts in that field kit to look like fentanyl. So if it's different, something different in that, because otherwise, they're going to have meth, think it's fentanyl.
Yeah, I think that it is different. I can follow up though and I can send you the link with more information about it. So.
Other questions? Yep, Greg.
This is more of a statement. Not only are we a forensic toxicology lab, but we're a compliance toxicology lab, which means that we get urine samples from treatment centers and from doctors' offices because they want to make sure that the drugs they're prescribing are in fact found in the individual. So we have a lot of experience on this, but one of the things that I want to point out, this comes back to the conversation about good facilities. Right now, Florida has a lot of treatment facilities, and maybe you've seen the doctor on television. He kind of looks like a doctor, but he's not really a doctor. Call this number. The commercial runs at night at like 2 in the morning. Y'all seen this? Maybe not up at 2 in the morning. Anyway, Florida has a lot of treatment facilities that are basically gaming the system. And so when you start bringing more treatment facilities into your community, keep in mind that these treatment facilities can be reimbursed for those urine tests from those people who are coming in to seek treatment. So they're getting reimbursed from insurance companies for this. In Florida, they're busting these treatment facilities because rather than treating the addicts, it is more economic, well, they make more money if they continue to be a patient. And so they're having overdoses over and over and over again in a week at the same treatment facilities. So it's just a word of caution as we're like trying to think about policy and trying to bring more treatment facilities in. There is a way that you can do this completely wrong and just generate more deaths and more addicts.
I guess you're suggesting that the Florida model has done it wrong? When I was in the Navy, I was in Florida, and one of the command admins had a screensaver that ran at that time, because this was at the time of the hanging chads and the election issues, and it said, "We put the duh in Florida." It's still there.
And I know Leonard could speak to this, that's important, and we certainly do recognize that, treatment's a big word. It can mean a lot of different things. We're careful, my role, our role, court, is to, begin that process to get people appropriately linked up, and we're very careful about having assessments to try to get the right level, but also we're very thoughtful about who we utilize and how we do that. We have through everything through our probation department and the inpatient and outpatient services they have, but there's also, many people out in the community that do it well that we utilize. We use, Leonard in the Recovery Center, they work for a lot of our situations as a broker almost, if you will, they're the pros in that and to be able to help us navigate, what it is in the community, because we understand that there may be a lot of people doing it, but not everybody's doing it, at the same level, and so that we are aware of that. And certainly, not to say that we have it all figured out, but you raise a good point that certainly we understand. We want to get people linked with treatment, but we also understand that, again, that's a big word. They need the right kind of treatment, and that's a very important thing. And so we rely heavily on either the in-house ones that we have that can be monitored and can be looked at over time, but also the ones out in the community that are doing it the right way, and to be able to utilize people like Leonard who know who those people are and can help us with that is really important.
Let me just add that what we've discovered is that to give these individuals the best chance of having a successful outcome, it takes a continuum. And we often take for granted that an episode of treatment is the end-all, be-all to the problem that these individuals are facing. And the reality is an episode of treatment is just a small step in the direction on the journey to recovery. And recovery is a journey. It is a lifetime journey for many of these individuals. And the more chronic the condition is, the longer it takes for them to get their life back under control. So often the way the system presently works is that we put a person through an episode of care, and whether it's detox or residential care, and then we think this person can return to the community and be this new person that we are hoping they be, rather than the person that they were being when they entered in this situation in the first place. What we've discovered is that individuals with a chronic condition, it oftentimes takes 8 or 9 detox episodes before they begin to get sustained behavior change. Now, most providers aren't set up to deal with a detox experience 8 or 9 times. And most community members have given up on that individual by then because they think that there's just no hope here. But what we're discovering is that that is pretty much the norm. You put these people through these episodes over and over and over again, and then over time, I think the thing that makes the greatest impact on that sustained behavior change is the relationship that they begin to build with the care providers. Because what we're discovering is that we have people that have chronic conditions that we don't know what the outcome is going to be. But over time, it's that peer specialist that they are assigned to that work with them every day, sometimes for 3 or 4 years, that they develop this trust relationship with that is the biggest factor that began to influence this lasting behavior change. And then we have to work on all those other things that's going on in our lives. Whether they've got a criminal issue that they're dealing with, they've got a mental health issue that they're dealing with, they've got other physical health conditions that they're dealing with, all of that stuff has to get managed before you can expect this person to be able to sustain behavior change. The other thing that we are considering or discovering is that we have to give some significant consideration to the social network that they've developed while they're living this lifestyle. You would think that a person that's homeless, if you gave them shelter, then you would pretty much have their problem solved. What we're discovering is that these chronic individuals, you can put them in a home, but if you don't re-socialize them to live in that environment, they won't stay. And so these are individuals that's lived on the street for years. They may be compromised with mental health and addiction issues, but they have a lifestyle that they've become accustomed to. They know the people that they're surrounded. They actually develop a friendship, a community with these individuals. And when you take them out of that community, you would think they wouldn't miss them, but they do. And they end up returning to that block. Even if they decide to stay in the house, they'll return to that block so they can be with those individuals. So this is complicated work. It's not nearly as simple as it might appear to be when you think about, okay, they got an addiction issue, so we get them treatment, so we got the issue resolved. No, we've got the solution to the problem started. The real work is still in front of us.
I want to say one thing that, yeah, go ahead and clap for Leonard, that he mentioned early on that you know, when we talk about resource and you mentioned, you know, the detox beds, that's something that we need to be very mindful of in terms of resource that we really struggle with, especially when you're dealing with these opiate-related matters. You know, obviously there is great concern for risk of overdose, either intentional or unintentional, when it comes to the heroin users, fentanyl users, or all the different opiates. We will routinely see situations where, I mean, this is, all of these substances that we deal with are harmful. Some can be deadly, and some are literally life and death at the moment, and need to be addressed immediately. And a lot of the treatment facilities that may be available and out there, people, if they are in need of detox, some of those facilities are not equipped to start the treatment part of it, as you would understand, until the medical situation, the detox, has taken place. And that is something that is a challenge in terms of availability for those beds as well. There are some that we are able to utilize, but there is a need out there when it comes to this particular population and this issue. Unfortunately, one of the places that does it well, that has to be used, is the Harris County Jail at times. There are others out in the community, but there is not near the capacity to meet the need, and that's a challenge that we deal with every day, and that's something that we work with Leonard on, all the time of, when we can, as appropriate, get somebody into a detox bed to get them into treatment right away, that has to be dealt with, of the availability of those detox beds, because for those issues, we can't even get started with the treatment part of it until that part is dealt with. And it's a real challenge and issue when it comes to these opiate matters.
And I'd just like to follow up on those points. As far as detox beds, in terms of funding, I believe there's one, and you guys can correct me if I'm wrong, one state-funded treatment provider in this area that does detox, which is Senecor. So if you don't have insurance and you need detox, there are not a lot of places, again, to go. Senecor, or like Judge Thomas said, the jail. And also, looking at what Leonard was saying, what they're doing at the Sobering Center with the aftercare and the case management, right now, insurance and state funding isn't set up for that. So, insurance providers will try to cover the least intensive care possible. So, if they think you can be covered with outpatient, they'll cover outpatient, not residential treatment. State funding treatment, usually in 30-day increments, not usually more than 90 days. And then what happens at the end of that period? It doesn't really address the issue of aftercare or long-term solutions of better integrating people into society so that they don't go back to drug use. So that funding structure is also an issue that exacerbates the problem that we have now.
Good morning. My name is Sadrina, and I am a recovery coach in the courts, and I work under Mr. Leonard Kincaid and Judge Brock. I'm both of their babies. Okay. So I am let me stand up. I am the result of Star Drug Court, and I am a recovery coach, and there is another facility that does government-funded detox for women, and that's Santa Maria. Senecor does detox for male and female. A lot of other facilities offer detox, but you have to have insurance. We see a lot of clients, participants, that if they have Medicaid, they can get the help they need. But with Medicaid, it's only up to 30 days of services. But what we offer at the Houston Recovery Center is 18 months. So during the process of treatment, we are with them in treatment, through detox, through treatment, and after treatment. And we have a clinical team that helps the individual to possibly get into sober living in a different environment. We don't just, once they get out of treatment, they're on their own. We're still there with them even after treatment, to encourage them, to support them. We have a lot of individuals that may have CPS cases. We have a lot of individuals that may have lost their children. But I know for me, when I came into the process of my first drug case, I was immediately sent to prison. That didn't help my addiction. And so later on in life, at the age of 39, I was finally offered that help. And when I accepted the help is when my life changed, but also you have people in the system that have a heart of compassion. And that's what the addict needs, is those with compassion, to understand them. And even though you may not sometimes understand why, but to let them know that you're there for them no matter what. And that's what the recovery support does. It offers them that support no matter what. Even if they use, we still work with them. If they relapse, we still work with them, and that's important to them. And so if they do relapse, they don't call the courts or their lawyer first, they call us. And so we're there for them, and we pick up the phone. And that's what has helped change some of their lives. Thank you.
Anybody else have any questions? I've got one last one if there aren't any others. All right, so Since we've got a variety of range of things here, and we've got Texas legislative session coming up, starting not so far away, thinking about past drug epidemics, crack epidemic of the 80s, what's different about that from this, and what are, so obviously everybody, number one thing that needs to get advocated for is funding. Well, we all know how well that goes, all of the complexities that go with that. What are, if you were to design an advocacy program to take to the ledge, or to city councils, or to those that may have the ability to change some of these rules, what are some of the top things that we should go and advocate for? I mean, I heard one out here of some of the data availability. How do we get better data? Those are things that are relatively easy, relatively low cost for a legislature, but are there other things? But like I say, funding, yeah.
I'm just going to start the conversation by saying that, first and foremost, we should understand that we're trying to save lives. And so things like Good Sam laws, which are Good Samaritan laws, which basically says that if you're overdosing with a friend and your friend is dying, you can call the police and it's no harm, no foul. They cannot arrest you at that point because you've called the police because your friend is dying. We've had far too many people die because people have dumped them in front of their parents' homes, already dead. They've left them in cars, they've left them in other places. But they were with people when they were overdosing. And essentially, we need to start thinking from the back end, if you will, about what saves lives first. I think Judge Brock, they call me.
They call me a lot of...
Can they do that? Oh, okay. But here's the thing, that people are at different stages, and you have to take them the stage that they're in. And I think we need to sort of consider what stage people are in and what immediate work that needs. I mean, I don't know, I know nothing about policy. But again, I seem to think that we need to come from a place of saving lives.
I would add, I mentioned in the slides that needle exchange programs and safe consumption sites are two public health ways of dealing with this epidemic that we wouldn't need the state legislature to put a lot of money to it. They could just say that, we'll allow cities and localities to put resources towards this if they wish. So that's something that I would certainly like to see the Texas legislature do. The other thing, and there's been a lot of conversation about this, but right now, possession of any controlled substance less than a gram other than marijuana is a felony. What the RIC Court is doing, I think, is great, and all these diversion efforts are really fantastic. I think we should keep doing them, but at the end of the day, it's still a felony for somebody who has possession of controlled substance of less than a gram. So that puts an additional burden on a person's life that's already dealing with a lot of other things. I think that's something, if we could see that reduced to a misdemeanor, I think that would be important to help address some of the problems that people have in their lives when they get into contact with the criminal justice system. And it's not something that would cost money. If anything, it would save money. Because we would have less people that would have to sit in jail because they have a state jail felony.
Let me just say, to address what we are doing with regard to that, of the diversions we are making, the majority of our cases are getting pretrial intervention, and that's for typically first offenders, and now they've expanded that to even some that are not true first offenders. What that means is, as opposed to pleading guilty, finding sufficient evidence to find you guilty, and having a conviction, the case is actually a one-year contract linked with treatment, a dismissal that comes at the end of the completion of that, and the ability to get the case expunged after a period of time there. To where, and I know that there's all kinds of different opinions about felony, misdemeanor, but if it works right with that, that is something that disappears off one's record at any level, and so that's important. And because and I've learned to, unfortunately, be good at stating the obvious, but when we look at so many of our people that are repeat offenders that have come through the system over and over again, every one of those was a first offender at some point. I mean, imagine what it would look like if we did a better job of getting that right out of the gate. And I think what we're looking at, what we are doing, what others are beginning to do, we're not the first to do it, we're just doing it on a big scale, and we're learning as we go. But these pretrial interventions, incentivizing people to be able to participate in it, much different incentive to take a deferred adjudication. Phil, others, the attorneys, you recognize this. Getting a dismissal and expunction out of that's a different incentive than taking a probation, and that flows from that. So creating those incentives, being able to yield those results are important when it comes to that. We have to, the better that we do with that, the impact that that's going to have over time is huge. And I will say, I was in Austin a few weeks ago, have been a couple of times, talked specifically in front of the legislature about the opioid issue. This is an issue when it comes to treatment that there is agreement, on both sides of the aisle when it comes to that. There are conservative, liberal groups, however you want to phrase that. I mean, there is a space within criminal justice reform, not to say that everything is agreed upon and there's not differences of opinion on how deep and how far, but there is space there where there is agreement within the legislature, there is agreement from all different sides that treatment works, more diversion opportunities are the right thing, they're the right thing to do, but they're also cost effective. And I think there is opportunity that it won't be perfect, and it's not, the be all end all. But I will say, even though we are still dealing with many more of the cocaine related matters and meth matters, if because of the opioid issue and the attention that's driving, helps to push us forward overall with the recognition of more treatment and more resource, and great for that. And I think that conversation helps in that recognition with that. But I do believe that there is, whatever that looks like, that there will be movement and that there is bipartisan agreement on that issue in a lot of ways that people may not necessarily believe to be the case. And then we've seen that. There's consensus on this stuff works. It needs to be addressed. It's not working in the way we've been done it. And there is a smart way to do it that is good for the individuals, that's good for public safety as well. We don't have to do one at the expense of one another when it comes to this.
So I don't really know how to make this a statement that goes before the legislature. What I'd like to speak to is what we've accomplished and what's left to be done to have a full, robust care continuum, a care system. And I'll rely on Catherine to assist us in making this a policy position that we can put before the legislatures. But what we've created is the beginning of a care system where we have these early points of intervention with the courts, with law enforcement, with the emergency centers, and with EMS. Those are all early points of intervention where we can catch people actively in their behavior of addiction use before they start looking for help, which is an ideal place to intervene. Once a person starts looking for help, they've kind of turned the corner. There's a huge population out there that are not even seeking help, and so that's the population where the biggest return on the investment, I think, could be realized for a community. And so we've already built a portion of the infrastructure necessary for us to do that. We have these early points of intervention relationships. Once we intervene on these people, though, we have to be able to do something with them, and we have to be able to do it in real time. Like when the person shows up and we say, would you like to get some help with this issue? And they say, yeah. Then the next stop on the continuum should be in front of a person that can start the process of giving them the help they need. That gets us to the problem that we face with the lack of resources in our community to do just that. It starts with detox, and then it's residential, and then it's the full care continuum necessary to support that person be able to stabilize their lives post-treatment. And so what we need focus on is how we build out the continuum, but there's a few pieces that's necessary to help us make this case. One of the pieces that's missing is the need for data sharing, data collection, number one. We talked about the idea of reporting not being where it could be when it comes to overdose, either in the hospitals or autopsies or what have you. To have a more robust system, and I think this is something that could be driven by legislature, that makes sure that we get data that represent what is truly happening across our community. Because I think that all of us see who work in this field that in this arena there is a huge underreporting of the issues as it comes to overdose especially. Okay, but once we get the data, and now we're sharing data in real time across these systems, we can do a better job of using all these points of care as a point of intervention, so that the individuals that's got issues can be brought to all of our attention, so we can put our team of professionals on that person's case to help address that problem. But beyond that, we need financial support for supporting that client as they go through this continuum. And that system may look something like more than just funding beds at a particular contractor, fund services that follow the client. So like the dollars kind of follow the client as that client moves through the system of care. And so I think that if we could get some support on that end, we have laid a foundation that is solid enough to be built on. We could end up with a pretty comprehensive system of care across our community.
And I think one of the key things that is necessary going forward, no matter what we do, is just the better availability of information. A lot of the things and these resources that the courts are providing are very useful, but at that point you're already in court with a felony sitting on your head, and you may not be in the best frame of mind to be enthusiastic about that or take advantage of things like that. And especially when it comes to these charges and the felonies, a lot of people may not know what they're getting in for. Those counterfeit alprazolam tablets I showed, 5 of those would be a misdemeanor, but if one of them has fentanyl, that's a felony now. And if all 5 of them have fentanyl, that's a higher level felony because you've gone over a gram. And if you have a rolled up cigar, if it has marijuana in it, that's a misdemeanor that could go through a diversion problem. If you have one of the sin cans that's become penalty group 1, that's also a felony amount in there too. So you may not even know what you're going in for, and it can vary randomly between the same kind of users.
Obviously, this is a huge problem. Very much want to thank all of our speakers today for coming in, for giving up their time to talk about this really important topic. I mean, yes, I'm a toxicologist. Yes, I'm part of a crime lab. We see this stuff all the day, but just straw poll in here. Who in here knows either friend, family member, neighbor who's had an opioid issue? And that's just this group. This is something that affects all of us. The numbers that are associated with this are enormous. This is 2 to 3% of our gross domestic product. I mean, this is gigantic. We can't afford to not deal with something about this. So I very much thank you all for coming and talking about this. I thank you all for coming. Hopefully this has been useful to you. Please, we will have this video up here as soon as Jordan can get stuff together. Please point people to it. If there's ever anything we can do to help with information about this, help with trying to find how we improve this for all of us, please let us know. But thank you very much for your attendance.
I hope you enjoyed your visit to Houston. Honey, I grew up here. Oh, yes, okay, you're home. Okay, very good.